who is Professor Tom Walley. He's a professor of clinical pharmacology at Liverpool University and also works as a consultant physician at the Royal Liverpool University Hospital. He formerly headed a research group at the Liverpool University focusing on drug prescription, pharmaceutical policy, and clinical effectiveness and cost effectiveness. Professor Tom Walley was director of England's NIHR HTA program for over a decade, up until the end of last year. As we heard earlier, this program is the largest publicly funded in the UK, with particular responsibility for systematic reviews and large clinical trials, funding over 50 trials a year. It has always had a strong focus on patient and public engagement, and in June 2008, he was awarded a CBE by the Queen for his services to medicine. He will highlight today the achievements of 25 years of publicly funded clinical trials.
Thank you very much. I'd like to thank KC for inviting me here today and to congratulate them on the excellent work they've done over the past 12 months. So I work for the National Health Service in the UK. So the National Health Service is a huge organisation. It employs 800,000 people. It's the second largest organisation in Europe. The largest organisation in Europe is the Russian army. So it's a big business, and a business this size should undertake research to improve the quality of its care and its business. But 10 years ago, we were in difficulty. The quality of clinical research in the UK was frankly poor because of systemic underinvestment over many years. So we went to the government, and we said to the government, you need to support clinical research. And they said, why do we need to support clinical research? And we had to make the argument to them. And the argument we made to them was that research will improve health outcomes. We will actually make people better by conducting research, by developing new technologies, and in that way improve the efficiency and the effectiveness of your health service. It will improve the ability of individuals in the health service to actually deliver care. They will perform better because they are research active. It will improve the standing of British science internationally. And the Treasury, our finance department, sort of shrugged and said, yes, yes, so what? And then we said, it will drive economic growth through investment in life sciences. And the Treasury said, well, why didn't you say so earlier? Of course you can have more money. So that was our promise to them and how we managed to get more money out of them. And on that basis, we were able to set up the National Institute for Health Research. So that our argument was that this was all about health and wealth, and the two would go hand in hand. We would improve health, and by improving health, we would first of all make the workforce more productive, we would limit the rise in costs in the health service, and we would give a vehicle through which our life sciences industry could actually develop its products for international sales. So in 2006, and it's our 10th birthday as well, not just TBM, but also our 10th birthday, we published a new policy, this document here, Best Research for Best Health. And it's full of very carefully weighted words. But I would draw your attentions to what to me are the key words in all of this, which are that the research was to be focused on the needs of patients and the public. And that's a big shift in what academic researchers were used to. They were used to doing research that was focused on what they thought was interesting. And here was a change in focus towards what the public and the health service actually need by way of research. So that led to the creation of the National Institute for Health Research. It's the research arm of the NHS. We got an increase in our budget. Our budget's about 1% of total NHS costs. Contrast that to a pharmaceutical company or to Apple or something like that. It's not enough, but it's not bad, as these things go. So I stole a slide from Professor Lockham earlier on about where are we actually focused. Because we're focused on patients and on the health service, we're not interested in undertaking basic biomedical research, nor even some very early stage clinical trials. We're focused on applied science, so we're focused on that end of the spectrum of research. So we're going to talk mainly about clinical trials today, but we undertake a whole range of different types of research, whether it's cohorts or whether it's systematic reviews. The key to us is there is a question that needs to be answered on behalf of society, patients and the health service. What is the most appropriate methodology to use to answer that question? So sometimes you can do a systematic review. There's lots of evidence out there. Sometimes there is no evidence out there, and we have to create new data. And that's what we have the ability to do. So NIHR is a large organization, a complex organization. Sarah showed you this picture, the dartboard diagram as we call it earlier on. A few key points to make about it. First of all, at the centre of it are patients and the public. And that's not just lip service, we really mean that. If a scientist puts an application into one of my programs and he doesn't have a patient as a co-applicant, it's going in the bin. We're not going to look at it seriously. This is somebody who really has not taken on board some of our fundamental principles. Outside that then are the NHS, the hospitals and the GPs, and beyond that, as supporters to all of this, are the universities. So the universities are not the driver here. It's very much driven by the needs of the health service. So some key elements. At the very top you see our training. We spend about 1/6 of our funding on training new future researchers. And that's a big investment, but if this is to be sustainable for the future, that's what we have to do. We spend a lot of money on our clinical research networks, and I'll talk very briefly about them as to what exactly they are. So they get about 1/4 of all our funding, and they consist of networks which are regionally based across the entire country, and these are networks of people to support research, not networks of researchers, but networks of people to support research. We have a small army of about 15,000 nurses distributed across the NHS who will act to support research wherever it's conducted, and we pay them directly. So that costs us about £250 million a year. It's a lot of money, and it means that we have a workforce readily available to support whatever research comes along. So when we fund a trial in the HTA programme, or when the pharmaceutical industry come to us with a new trial and they say, we'd like to run this in the NHS, we can say, well, here's a workforce ready to pick it up right now. So we've got a trained workforce in place, and that's what our networks are. And then the researchers can take advantage of this infrastructure to support the conduct of research. What I'm going to talk mainly about, however, are our research programmes, and I'm going to follow on from what Sarah talked about this morning in relation to the kind of programmes we have, and in particular, of course, we're interested today in those that support clinical trials. So again, you've seen this slide earlier this morning, and it shows some of our programmes, not all of our programmes, but some of them, and it's carefully thought out. It is a jigsaw. There are no clear demarcations between several of our programmes, because there are times we look at some things and we think, this is really service development, it's not really HTA, it doesn't necessarily sit within that particular trial. Or we have an earlier stage programme, the EME programme here. There was a question earlier on about how you would research a novel psychoactive agent. If it has a little proof of concept, that's where you'd go to get the proof of concept before you take it to a larger trial. So all of these programmes interdigitate. We pass projects between each of the programmes. We try to pull projects through to the best programme which will fund it and support it in that way. So the HTA programme is the one that's been around for the longest, for over 23 years now. And it's published a huge amount of work over that time. So we've done, we have, any given time, we've got about 300 studies, 300 trials underway, and we've added about 50 new trials to that portfolio every year. And we publish these in lots of places. So I'll talk about some of the trials in a few moments, but this is my trophy board. So Sally Lamb talked about her trophies earlier on, and how important it is to publish in these journals for academic credibility. And Frank said earlier on, well, it doesn't matter whether you publish in the New England Journal. And in one respect it doesn't. But actually they're both right, because we need the academic credibility that producing studies of this quality gives us. And that's also credibility with ministers, because we have to keep the politicians happy to convince them we're doing good work. So this is international recognition for the quality of our work. But that alone will not change clinical practice. And that's, of course, what we're really interested in. How do we actually improve care for patients? So just on the subject of publication, I will show you this graph. So this is a graph published about 3 years ago, and it looks at the rate of publication by funder. And you can see that most funders publish around about 50% of the outcomes of their work. So if you go to NIH and get a project funded, or if you go to industry, roughly only about half of the work ever done is actually published. And we think that's disgraceful, because a lot of the benefit, even if a trial was negative, the learning in conducting that study is now wasted because it's never published. So we have a contract with our researchers. We say to them, you will publish. There are no two ways about it. And our publication rate is 98%. The only 2% get away because they fail before they ever get anywhere. How do we achieve that? Well, a couple of ways. First of all, we have our own journal, and we publish everything in our own journal. And if someone is slow to publish, I am not above going and threatening him or threatening his institution. You will never get another penny as long as you live if you don't publish quickly. And we insist that people publish within 12 months of the conclusion of a study. Whatever the results are, I'm completely neutral about whether a particular technology works or not. But I do want an answer to the question, because that's what the health service needs at the end of the day. So we force publication. And someone asked about data earlier on. The owner of the data is the researcher, but the researcher, according to his contract with us, may not withhold that data from other researchers who may wish to use it in an individual patient data meta-analysis or whatever. So we're very clear on that. The IP may rest with the researcher, but really this is about public good at the end of the day. So the question is, does our work actually change practice? So let me give you two examples. You've seen one of them already, but I'll come back to it later on. So here's a study looking at the use of tranexamic acid in the treatment of trauma. And tranexamic acid is a drug which blocks the breakdown of fibrin, and therefore it's procoagulant and reduces bleeding. And there was great concern that if you gave such a drug to people with trauma, it might indeed stop the bleeding, but it might cause myocardial infarction or stroke. So we funded this study, the CRASH-2 study, 20,000 patients, and demonstrated about a 10% reduction in mortality. Large study, simple outcomes. You can't usually argue too much with death as an outcome in these studies. And okay, so we've got a result. Now what do we do with it? Well, the chief investigator in this study was very, very clued in. He struggled to get this adapted by the NHS because the NHS is a very conservative organisation. So he went to the British Army, who were in Afghanistan, and he persuaded them to start using it. And as soon as the British Army in Afghanistan started using tranexamic acid in the backs of armoured ambulances, suddenly every paramedic in the entire country, who like to think themselves perhaps as rather cutting edge and a bit military and so forth, they were also keen to start using this drug, and in no time at all everybody's using it. And this is now standard care in the UK. So this has worked very well. Here's another example, also from the ambulance service, and Sarah showed you this one this morning, the paramedic study. So this was a study of the Lucas device. The Lucas device is a compressed air device that delivers chest compressions automatically in cardiopulmonary resuscitation. And many ambulance services in the UK were starting to buy these devices. There was a window, when they hadn't all bought them yet, when we could do a trial. Had we left it too late, it would be impossible. They'd all have the devices. There was a period when they were starting to buy these, we could do the trial. So we did the trial. The trial showed no benefit. The ambulance services stopped buying these devices. We have saved the NHS money. And from my point of view, and from the point of view of the health service, it's important to realise that a negative study that shows that something doesn't work is every bit as valuable as one that shows that something does work. So we're very keen on definite results. I'm not too keen on that group in the middle where the sort of equipoise. I like definite results one side or the other, but they're equally valid. So research does more than that. Here's an example of a study we did looking at endovascular repair, vascular repair of aortic aneurysms. And the options were open surgery or endovascular repair by an interventional radiologist. And at the time this study started, interventional radiologists and surgeons did not talk to one another. They were opposed. They had different technologies. They each wanted to promote their own technology. We said, let's do a trial. And they agreed. And now they had to start talking to one another. And the simple conduct of that study changed the nature of vascular surgery in the UK. It concentrated into much stronger individual centres rather than every little hospital trying to do it, because not every hospital could have an interventional radiologist. So it improved the standard of vascular surgery. Just the conduct of the research, not the results, just conducting the research. It also published in eminent journals, fortunately. Here's another example of care changing as a result of the conduct of the research. So if an elderly patient falls, fractures the distal radius, sometimes it needs operative repair, often doesn't, but it could be done with a plate or with K-wires, Kirchner wires. And we did a trial comparing the two. And you can see, before the trial started, most patients were getting the very expensive plate rather than the cheaper wires. As the trial went on, clinicians started to think, maybe this is not such a good idea. And bit by bit, practice changed. And in fact, the study has shown that the much cheaper K-wires is as effective as the very expensive plate. So again, even before the results were out, practice was changing. I would like to think that all our research changes practice, not necessarily, because you can put evidence out there and everybody ignores it. But in the UK, we're fortunate. We have another vehicle to help us change practice, which is the National Institute for Clinical Excellence, which publishes guidelines, and clinicians in the NHS are expected to conform to those guidelines and may be monitored against it. And about 74% of all NICE guidance is informed by some of our research. So as well as the clinicians taking on board the results of the research, as well as the conduct of the research, we have another vehicle to push the implementation of our research, and it's a powerful tool. Now, as a researcher, we also have to be researched. We have to question, are we doing any good? So we funded this study. It was done by the RAND organisation, looking at our own impact. And we were relieved to say that this study demonstrated that we had indeed had a very major impact on healthcare in the UK, and that information feeds into every 5 years the government have a comprehensive spending review, and this guarantees our funding for the next 5 years. So we were relieved at the results. So we have to question ourselves, is what we do actually improving healthcare? And we think it does. So I mentioned earlier on that just conducting research changes practice, but just conducting research also improves the quality of routine care. So there are several studies, and this is one example, which have demonstrated that engagement in research actually improves the outcomes, not just in the areas of the patients being researched, but across the entire hospital. So it raises the quality of work in the whole area. And that's really important to us and justifies our argument to the Treasury much earlier on. But government are interested in growth, and we make a strong pitch to industry, not just pharmaceutical industry, but all healthcare industries. So the NIHR is seen as a vehicle for economic growth. This was our former minister here proclaiming the importance of this, and it is important to us. We have to demonstrate this repeatedly. Otherwise, the funding would dry up from the government if they didn't think this was a worthwhile exercise on our part. So we're open to studies either in parallel with industry or in collaboration with industry. Industry can access our workforce, our networks, with a large number of staff ready to take up studies and conduct them in a quick and speedy manner. We offer this study support service, which, if the industry comes to us, we will actually undertake all of these. We will find the researchers for them. We will help them get the work through the various committees that it has to be approved by. Sometimes we'll help them with design. So we're very determined to be industry friendly, because this is a major imperative for the government and we have to pay attention to it. And it has shown dividends over the years in that research. We have shown that we have increased our recruitment to pharmaceutical company trials, in particular pharmaceutical company trials in the UK, but we don't do it all as well as Belgium. Belgium is probably the world leader in numbers of participants in pharmaceutical industry trials per head of population. So we're chasing you. So we're not there yet. So, last comments. Have we been successful? We think we have. And how have we been successful? We've been successful because we had a very solid foundation, both in the quality of UK healthcare science and in the quality of basic science in the UK, and in the clinical environment in which research could be conducted. We've had a lot of government support over the years. We've convinced them that research does improve health and that research does lead to economic growth, and that's been very important. I think we've succeeded because we've been very clearly focused on the needs of the health service and on patients, and that's really important to everything we've achieved over the past few years. But we've succeeded by working together with patients, with industry, with the health service and with academia, and that's perhaps how we've achieved most of our success. And there are lots of challenges ahead for the National Health Service. So we've got an ageing population. How are we going to deliver care for this ageing population? Increased incidence of increased prevalence of dementia, perhaps an altered workforce as well. as the population grows older. There are new technologies, genomic marking for identification for drug therapies and so on, and we're trying to take all these on board at a time of major economic austerity, because there isn't enough money in the health service. There will never be enough money in any health service. And we think that research is going to be key to helping the NHS manage all of this. So we hope that NIHR is going to be a key element in that future for the health service. Thank you.
What I recall is that you spent quite a lot of money in training of the new generation of scientists of all levels. But in this country, the major complaint of clinical scientists is that there is increasing pressure on taking care of clinical activity rather than spending the time of research. I think there will be unanimous confirmation of what I just said. How in your country can you use the money from your institution to support not just the trainees, but the career and the life performance of the clinical scientists?
So this is really important to us. As I say, we spend about a sixth of our budget on this, about £150 million a year, and we have programs at every level. We have programs for junior doctors or other clinicians, not just doctors. We have programs for methodologists, right through to full research professorships, which we fund. And it hasn't been running long enough for anyone to go right through from junior doctor through to research professorship yet, although in theory that could happen. But I think it recognises the importance of training looking forward 20, 25 years. And again, going back 10 years ago, exactly what you described was our problem, that everybody's looking after patients. Who has time to do research? Who has time to train to do research? Because research is not something you can do between 5 and 6 on a Saturday afternoon. It's a very professional job and you need proper training to do it. So we carved this work out. There were previously research training programs available, but most of those focused on basic biomedical science rather than applied clinical science and on clinical trials. So it has been a battle. It is still a battle. Clinical service is still very demanding, but I think we've got a strong stake here, and I think it's an extent of our vision that we had to push that training in at a very early stage and keep it strong.
You obviously put at the centre of your program the patient needs and the patients, which you also try to do in the Netherlands, I think. And you say that if a patient is not a good applicant, your application is just being discarded, basically. How do you prevent that someone's name or organization just being put up there for window dressing, and how do you consolidate this process?
So it starts right at the very beginning of all our processes. So for instance, Sarah talked about the prioritisation panels, about what topics are we going to advertise as being important. We have patient representatives sitting on those. If the patients don't think it's important, it's gone. At all our funding boards, we have at least 2 patient representatives, and they will particularly look out for evidence of patient involvement. And clinicians' understanding of this has changed over the years. So in the very early days when we started doing this, we had a box in our form saying, how have you involved patients in the development of this project? Or how will you involve patients in the development of this project? And one researcher, my favourite line, he wrote in it, well, they're the ones we're going to experiment on. So the understanding of what patient engagement actually is has changed a lot as time goes by, and we're very skilled at picking out this kind of tokenism. It's definitely not tokenism. It better be there, or it'll go, as I said, it'll go into the bin.